First of all, welcome everybody to this supplementary roundtable discussion. Uh, Once again, we apologize that there were some technical glitches during the Thrombosis Canada meeting that precluded some of our online attendees to have the optimal experience in terms of participation. So we hope this will provide those individuals and others, if they have other questions in dealing with this topic. Once again, the format is meant to be very, very informal. We are really gathered around a very large table right now, and it's more about learning from each other, sharing experiences with cases, bringing forth challenging cases. And often with these sessions, we don't have one clear black or white answer, but we want to see, how people would handle situations like this in different clinical settings. So it's more about learning from each other and looking at maybe if there's a diversity of management options as opposed to identifying what is the one correct answer, if you will. So let's get started. My name is Jim Douketis. I'm an internist and a thrombosis physician in Hamilton, and it's my pleasure to welcome you all to this session. And I would like to thank Holly Devlin from Thrombosis Canada for organizing this and for your time. In terms of some disclosures, here are mine that may be pertinent to today's discussion. And I will also disclose that the conference, the Thrombosis Canada conference, received financial support from the following entities in the form of conference grants, and that the benefit from the sale of one or more products may accrue from discussions in general from the Thrombosis Canada conference. There are ways that we have tried to mitigate potential bias in this and the entire conference, as you can see here. And if you do feel that there are areas where there may be bias in our discussions, please feel free to share these thoughts during the evaluation. We'd like you to fill complete. Take a few minutes, because this is what we base our decisions about conference topics, and we want to reflect the needs of clinicians like myself and others in dealing with these areas. All right, so we're going to get started, and I'm going to keep a keen eye on the chat line. So if you do have a question or a comment, please put your hand up or enter something in the chat, and I will try to stop and pause for discussion. That's the whole point of this. We're at a round table. So once again, welcome, and let's get started. So here is a typical case that involves a special population, and in this case, patients who have impaired renal function, a 55-year-old male with a history of diabetes and associated chronic kidney disease with a baseline creatinine clearance of about 35 ml per minute. So they are close to the severe renal insufficiency category, but would be classified technically as moderate renal insufficiency. This person is diagnosed with an unprovoked pulmonary embolism. So we can consider what are the treatment options for this patient, and maybe to get us started, would anybody like to propose a treatment for this individual given these characteristics? Well, I'll get us started. When somebody has a creatinine clearance kind of in that borderline area, the 35, we know that this can vary over time. It can be as high as 40 or as low as 30 or even less than that. So we have to consider our treatment, not just in the short term, but in the long term, and try to anticipate that patients like this may run into intercurrent illnesses and have worsening renal function. So I got on the chat line, one of our colleagues suggested treatment with a direct oral anticoagulant, in this case, a Pixaband. And there was another comment about a bit of divergence, between anesthesia guidelines and Thrombosis Canada guidelines as regard to stopping anticoagulants. What is my practice? I think I will address that. It's a little bit different and an important question. What is the weight of the patient? Well, I don't have that, but let's assume that this is not an obese person. They're of standard weight. We will be talking about patients at the extremes of weight. So in terms of the options, I think one of our colleagues mentioned a direct oral anticoagulant. And if we consider that this is their baseline renal function, this is quite reasonable because there are no restrictions down to a creatinine clearance of 30 ml per minute. So a DOAC would be a sensible option. And we know that all DOACs are not the same in terms of their clearance through the kidney. It's about 25 to 30% for a Pixaband, maybe 30 to 35% for rivaroxaban, maybe around 45 to 50% for edoxaban, and then for dabigatran, 75 to 80%. So bear in mind that not all DOACs are created equal in terms of how they are cleared by the kidney. And another comment, I think very reasonable, is, well, what about if this person is in a rural area where the follow-up is not so great? And as I mentioned, what if their renal function might deteriorate? Would this influence our decision making? So getting back to the options overall, so I think any of the DOACs would be acceptable. And of course, treating this patient with a short period of low molecular weight heparin as a bridge to warfarin would also be an option. So overall, we've got a broad spectrum of choices here, DOACs, non-DOACs. And in regard to this being a, let's say, 75, 80 kilo person, is there one agent that would be preferred? I personally don't have a preference. I think the participant who suggested, well, what if we can't monitor this person? Then, all right, I think it would be sensible to consider either warfarin and a low molecular weight heparin, where we can't maybe monitor the creatinine clearance, but perhaps we can monitor the INR. In this case, maybe this person has a point of care device if they live in a remote area. But I think more practical and more easier to deal with is to treat this patient with a DOAC. And I think Pixaband would be a good choice. Rivaroxaban would be another good choice. I probably would steer away from dabigatran because of the potential for, worsening renal function. And I think edoxaban is another option as well, but it requires a lead-in period of low molecular weight heparin, as does dabigatran, of about 4 to 6 days. So I think the comment about Pixaband or maybe rivaroxaban, especially if follow-up blood testing is not feasible for INR testing, I think are reasonable choices. And the point is overall that there isn't one singular correct answer here, and it's predicated on a number of things like the clinical setting. Okay, any other comments about that? Was there someone around the table who might treat this person differently, maybe not a Pixaband or rivaroxaban? Any experiences with the other forms of treatment that we've sort of laid out? Okay, And I think the other comment just that was made, I believe by Greg, was what if the patient had no primary care physician? I think the only caveat there, we do see these patients, especially in regions where they're disadvantaged economically, and we need to make sure that they do have some follow-up. So in my practice, at least, I sometimes act as the de facto primary care physician, because I just don't want to have a kind of fire and forget, and then I'll see you in 3 to 6 months type of approach. I think this patient with an unprovoked PE who has comorbidities probably warrants some clinical follow-up and maybe some laboratory follow-up as well. And there's a comment from Dr. Nguyen about the use of rivaroxaban. Yes, this is an option as well in this patient. We know that with rivaroxaban, when chronic atrial fibrillation, we reduce the dose, but for acute venous thromboembolism, with this creatinine clearance, we still want to give a standard dose of rivaroxaban, 15 milligrams twice a day for 3 weeks, followed by 20 milligrams a day thereafter. So this is a different situation than chronic atrial fibrillation, where if you've got somebody with a creatinine clearance between 30 and 50 ml per minute, you downgrade that dose to 15 milligrams once a day. So this is because with acute venous thromboembolism, we may not be treating this person indefinitely at that sort of higher dose of 20 milligrams once a day. And Greg soon mentions that family health teams often have INR clinics, and then warfarin is a reasonable option. Yes, it is. If we look at the evidence comparing the DOACs versus warfarin for acute VTE, there isn't really as much of a difference in terms of efficacy and safety as we see in the atrial fibrillation population. So I think warfarin is still a good choice. Of course, we need to be mindful of drug interactions, as we do with DOACs, but to a lesser extent, and most importantly, monitoring. Okay. Any other comments? Please feel free to just put them into the chat line, and I will try to address them. So Martin Bauer, I believe Dr. Bauer mentions if the GFR is 15 to 20 ml per minute, is there a preference of a Pixaband versus rivaroxaban? Well, Martin, that's a very good question. I think we need to start off by looking at what kind of evidence do we have from clinical trials on using these two DOACs, Pixaband and rivaroxaban, in patients who have severe renal insufficiency. And there's not a plethora of data in this area. There's some observational studies. And we know, of course, that once you get to a GFR at that level, it can be quite dynamic. It can drop even further or go up, depending on a number of clinical factors, as we all know. And would I have a preference of a Pixaband versus rivaroxaban? On face value, you'd say, well, Pixaband's a little more renal friendly than rivaroxaban, but I don't really know whether that's going to make a clinical difference in terms of bioaccumulation, in terms of bleeding risk. All we can say is that with that GFR, we have to be careful with a DOAC, and it would be completely fine for that person to be treated with a heparin for 4 to 5 days as a bridge to a vitamin K antagonist like warfarin. So I probably would be a little careful about just using a DOAC therapy in a patient with a GFR in the 15 to 20 ml range, especially with acute venous thromboembolism where we're using higher doses for 1 to 3 weeks. if this patient had atrial fibrillation, we have the option to use a lower dose regimen of a DOAC, whether it's a Pixaband 2.5 milligrams twice a day. It's, again, not studied as well, but, in practice, we've used that down to a GFR of about 15 ml. And then, as Dr. Diem Nguyen, what if the patient is on hemo or peritoneal dialysis? Is it safe to use a DOAC? Well, as you get worse in terms of your renal insufficiency, and then you are dialysis dependent, the amount of evidence that we have is progressively less and less. So we know that it is, I guess, from the product monograph standpoint, contraindicated in patients who are dialysis dependent. And there are some data that came out in the United States a couple years ago, and in fact, the FDA approved the use of low dose of Pixaband for dialysis-dependent patients. And I'm still not completely convinced of the safety in that clinical situation, but I know that there are some colleagues that have used the Pixaband at a low dose in dialysis patients for some time, because they're just really worried about warfarin in dialysis patients because of the potential for bleeding complications, the potential for calciphylaxis. So I know a lot of nephrologists don't like using warfarin in their dialysis patients, period, unless there's no other choice. Now, in this situation, we got to remember that this patient has acute venous thromboembolism. So I don't think a low dose DOAC would be an option. So for a dialysis patient, I would certainly go to warfarin, and you can either use sub-Q unfractionated heparin as the initial bridge. And there are some data on low molecular weight heparins in dialysis patients for short periods of time. Again, I'm referring to 4 to 5 days while you're bridging them with warfarin. So no, I don't think DOAC would be, at least on my option list, if the patient is on dialysis. All right, good. Excellent questions. I'm going to move on. And so in this patient, a few years later, his kidney function has worsened, and now his eGFR is at 13 ml per minute. So I'm assuming that we started this person off, maybe, as was mentioned by one of the panelists, on a DOAC, let's say a Pixaband, and they would have been receiving 5 milligrams twice a day. And sometimes after acute venous thromboembolism, especially if it's idiopathic or unprovoked, we may decrease that dose a bit. So with rivaroxaban, we may go to 10 milligrams a day. With the Pixaband, we may go to 2.5 milligrams a day. So this person may already be on a lower dose regimen after their initial 3 to 6 months of sort of full dose treatment. And if that's the case and their GFR is 13, well, I'm starting to get a little nervous, because if this person is on lifelong or long-term anticoagulation for secondary prevention of VTE, I get a little nervous if that GFR is below 15, even with a low dose of Pixaband management. So it's something that you have to watch carefully. I don't think there's a right answer here. You can go back to warfarin. That's always your default anticoagulant for long-term management. I think for me personally, for what it's worth, I would keep them on the 2.5 milligrams twice a day and watch their creatinine clearance carefully. Now, one question that comes up in this situation is, why don't we do some monitoring or measurement of the DOAC levels? So there are anti-factor Xa assays available. that you might be able to use. But as we heard from the conference, and it was Karen Moffat, the laboratory specialist, who did a presentation, you may recall, that very, very few laboratories in Ontario, at least, and probably the same in other parts of the country, have this capacity. And even if they do have a capacity to measure anti-factor Xa levels, the turnaround time is going to be, a day or even more. Maybe in this clinical situation, that's acceptable to have a long turnaround time. But the other factor is, what are we measuring? When are we measuring it? And how are we interpreting? So let's just say hypothetically, and I stress the word hypothetically because I'm not suggesting that this should be done, but let's just say we're going to measure this person's Pixaband levels. When would we do it? And anyone want to venture a guess on what the level might be and how we would interpret this level, and whether this level would lead us to change the dose of Pixaband? Now, this is a tough question, so I'm not seeing any hands up or any volunteers on the chat line. I think this is an area where we don't have a lot of evidence. It's really all just some case series or patient registries. But really, yeah, so Greg and others, no experience with levels, agreed. I think the only thing I want to convey here is that, I mean, in general, with any drug that we're looking at, whether it's an antibiotic or, an anti-immune function regulating drug, and we're worried about over accumulation, then we want to measure a trough level. So we want to make sure, is that trough level coming down, or is there evidence of bioaccumulation? So if hypothetically you would want to do that, you would want to measure a trough level. And I'm getting a comment here, and I'm just going to read it out for everybody. If available, the preferred test to rule out clinically significant serum concentrations and quantify anticoagulant effects is anti-factor Xa activity, calibrated specifically for Pixaband. And in parentheses, undetectable anti-Xa activity likely excludes clinically relevant drug concentrations. An anti-factor Xa assay calibrated for LMWH can rule out clinically relevant drug concentrations, but is not useful for quantification. So I know the papers that you're referring to, those are ACC and NHA guidelines, and really they're kind of a generic statement. They don't really help you too much, at least in my view, other than, you have to use a specific assay that's calibrated to the drug you want to measure. But the point is that we don't really know what a trough level is. We don't know what a peak level is. We sort of know a little bit for patients who are on a low molecular weight heparin. So we sort of know that maybe a peak or a therapeutic level is between 0.5 and 1.0 units per ml for twice daily dosing, and between 0.5 and 1.5 units per ml for once daily low molecular weight heparin dosing. But we really don't know what that is for DOACs. It's measured in a nanogram per ml. Units is less than 50 nanograms per ml. An appropriate trough level is a peak level, between 100 and 150, or 100 and 200, and 150 to 200 appropriate peak level. It's not really established. So this has not been done in a way that has been done for the INR or perhaps the PTT in heparin-treated patients. So more questions than answers. My management for this patient would be to not do DOAC levels, to monitor their kidney function closely. And if that eGFR is creeping down further, and this patient may be destined for hemo or peritoneal dialysis, then it is quite reasonable to switch them to a warfarin or equivalent. And in the meantime, I'd use a low dose regimen like a Pixaband, 2.5 milligrams twice a day, or rivaroxaban, 10 milligrams once a day. Sorry. The other option may be edoxaban, 30 milligrams twice a day. I would definitely avoid dabigatran. Okay, we can come back to this scenario, but I want to have enough time to cover some of the other cases and some of your cases. So now we go on to a 53-year-old man with a history of hypertension who is receiving a calcium channel blocker, presents to the emergency department with left leg pain, and is diagnosed with deep vein thrombosis that is considered idiopathic and unprovoked. His weight is 150 kilos. And thank you very much to Dr. Ritchie for that link about a review of anticoagulation in patients with end-stage renal disease. I'm going to definitely have a look at it, and I hope that I'm not misleading too many folks during the discussion today. But I think this is an area that most definitely requires more research. So back to the case. So 150 kilograms, or about 330 pounds. And what are our options here in terms of anticoagulation? Is there a concern about using a direct oral anticoagulant? And if we do so, should we be checking the levels? And we just talked about a minute ago, not checking levels routinely. So here we're dealing with a different sort of special population situation, but something that is not that uncommon. In fact, I just had a patient on the weekend who was 140 kilos and had extensive iliofemoral deep vein thrombosis, possibly precipitated by our oral contraceptive use. And I was called on the weekend during the Thrombosis Canada meeting, and I suggested that this person would not be eligible for a DOAC. And the other problem with this patient I was dealing with is that they had poor venous access. So INR monitoring with warfarin would also be problematic. We can get to that a little bit later, but back to this case. So what are our options for anticoagulant management? Any kind of volunteers for this patient who weighs 150 kilos and has a new unprovoked deep vein thrombosis. And so once again, we have our standby, which is low molecular weight heparin and warfarin. I mean, the warfarin part is pretty straightforward. In terms of, if we were to use a low molecular weight heparin, let's just pick one, let's say dalteparin, would we use a weight-based dose without capping, which in this patient would be 15,000 units twice a day, so a total of 30,000 units. And we know that the product monograph sort of tells us to cap this at around 20,000 units. Getting a comment from Greg that in our ER, it would be low molecular weight heparin, and then discuss outpatient management, further management on an outpatient basis. So yes, you can use a low molecular weight heparin. I personally, my comfort level for what it's worth is about 30,000 units a day. And that's not based on any kind of science. If we look at guidance or guideline documents, they're kind of cutoff for using a DOAC is about 130 kilos. It used to be 120, and now they've relaxed that a bit. So clearly this is somebody who would not be within that DOAC acceptable weight range. And so you could use a low molecular weight heparin for a few days and then transition them to warfarin. I would not feel comfortable using a DOAC in this individual. And for reasons we discussed before, I would not be doing that and measuring their levels, DOAC levels. And a comment from Dr. Nguyen that in CHUM, I think that's in Montreal, this patient would be receiving twice daily low molecular weight heparin. And getting back to the patient I had on the weekend, if INR monitoring is problematic, then you don't have a lot of options. It's really a low molecular weight heparin twice a day. We can't give enough so that it's a once a day injection. And I guess the other option might be unfractionated heparin. But the problem there is that you need to give a large volume. So it would typically be 300 units per kg, and that would entail a large volume of heparin that you're injecting, even if you're using the 25,000 unit per cc strength. So really we're left with a low molecular weight heparin and hoping that we can get INR levels on this patient. But the other sort of component of this discussion, I'm not sure if there are any pharmacologists in the audience there that might inform this, is that we're not quite sure when we're giving these high doses in the obese population, what is their volume of distribution? Is it the same as somebody who's non-obese? And do we have to worry about making sure that they have a weight-based dose? Can maybe if we cap them at 20 or 25 or 30,000 units, are they still getting enough drug within their circulation to have an appropriate pharmacodynamic effect? I don't know the answer to that question, but it's something that I think warrants further study. And until we have that, as I said, we our default will still be a low molecular weight heparin and warfarin in this patient. And I would not be checking DOAC levels. So let's go on. So this man is actually treated with a DOAC. Okay, it's not something that I would do, but he was treated with a DOAC, in this case rivaroxaban, with the standard loading dose of 15 milligrams twice daily for 3 weeks, my apologies, followed by 20 milligrams daily. And happily he improves and does not have any bleeding problems. As I said a minute ago, this is not something that I would do in this setting. We just do not have data on the efficacy and safety of DOACs in patients with a body weight, over 100 kilos. And the heavier the patients are, the less data that we have. There are some emerging data in patients in the 100 to 120 kilogram range. To my knowledge, not very much in patients in the 140 to 150 kilogram range. So I just don't know whether or not treating this person as I would a 75 kilogram individual would garner the same therapeutic response. And frankly, I don't think I would not feel comfortable using this treatment regimen. I suppose that it seemed to have worked in this specific instance, but I think if there was a problem, if the patient developed recurrence, it's not so much bleeding, because our concern is that we might be underdosing them than overdosing them. But if they had an extension or an embolization, which can occur in 3, 4, 5, 6% of patients, I might be hard pressed to justify my treatment in this setting. So I guess I'm being a bit more cautious, but in my view, this would not be the agent of choice. You might consider using a DOAC in the non-acute period. So once for the initial 1 month or 6 weeks, when that anticoagulant intensity is important to stabilize the clot, to allow the clot to be organized by the body's own endogenous anticoagulant system, I might see going to a DOAC if I can't use warfarin in more the subacute treatment phase, but I would be very hard pressed to use a DOAC up front in this kind of patient. Anyway, he does improve, and because he has unprovoked venous thromboembolism, it's decided to reduce his anticoagulation but continue treatment. And the question is, can we reduce rivaroxaban at 6 months as extended anticoagulation? Well, here you're using the same, you got the same limitation. You're not dealing with the acute situation, but you're dealing with a situation where we don't have any data or very little data, to my knowledge, on the efficacy, long-term efficacy of reduced dose rivaroxaban, in this case, 10 milligrams a day, as per the Einstein trials and extension trial, in terms of the efficacy for secondary prevention. So I probably, if I'm going to leave this person on a DOAC, I probably would leave them on the standard dose of 20 milligrams a day. This is completely empiric, mind you, as opposed to dropping their dose to a 10 milligram regimen. That would just be my practice, but it's by no means anchored on good quality evidence. So now this patient is seen in the clinic a few years later, and he continues on rivaroxaban. Let's say it's at 20 milligrams once a day. And now he is a candidate for bariatric surgery. And in this case, gastric bypass surgery, which in most institutions is a Roux-en-Y procedure. There is also a different type of restrictive procedure, which is the sleeve gastrectomy. The Roux-en-Y bypass is a diversionary kind of procedure to limit the absorption surface area, whereas the restrictive procedure, the sleeve gastrectomy, kind of reduces the volume within the stomach and intends to induce early satiety. Now, with any of these procedures, you're altering the anatomy of the gastrointestinal tract, and we know that DOACs are absorbed through the GI tract, and some of them are absorbed kind of throughout the GI tract, small bowel, large bowel, like dabigatran and rivaroxaban, whereas with Pixaband, it's more in the stomach and in the proximal small intestine. We also know with dabigatran, of course, that it is dependent on the acidic environment within the stomach to allow the capsule to release the active drug. So not all DOACs are the same in terms of where they are absorbed within the GI tract, and that has to take into consideration if we want to continue the DOAC in this patient. I think that there is now some emerging data actually looking at different DOACs following bariatric surgery, and suggesting that maybe we want to avoid those agents where the surgery may have an impact on absorption. So that's more something like rivaroxaban, where again you have to take it with your meal, and it's a sort of area that is absorbed where it is affected by the gastric bypass surgery. Pixaband and potentially edoxaban would be less influenced by this, although we don't really have a lot of data with edoxaban. I probably would be avoiding dabigatran. And once again, as has been the theme here, warfarin is always your default option for patients who have severely impaired renal function, are at the extremes of weight, and we didn't talk about patients who have a body weight less than 50 kilos, and in situations like this with bariatric surgery, and that would be completely acceptable for long-term anticoagulation. I guess the question again arises, somebody may be thinking, well, Jim, you're going to leave this person on rivaroxaban because, he's tolerated it well and it's had good efficacy. It would not be my choice, but Jim, what about doing some rivaroxaban levels? And now, unlike the situation before where we're worried about having too much of the drug in the system, here we're worried about having not enough drug in the circulation. And here is where you might want to do a peak level that is about 1 to 3 hours after intake, as opposed to the trough level, which would be 20 to 24 hours after intake. But I want to stress heavily that I'm not sure what I would do with the result. So if the result, I guess if it was really low, then maybe this is indicative of poor absorption of the drug. Whereas if it's in the 150 to 200 range, I'm a little bit more comfortable that we're getting therapeutic levels. I don't know what a level between 50 to 100 means clinically. As you can tell, I'm giving you more questions than I am answers. And I think the other consideration we have to look at is what the phenotype of the thrombosis was. I mean, is this a patient that had an extensive iliofemoral DVT, has had a recurrent DVT, or was it a small clot in the calf or just a popliteal vein? And frankly, does he need to be on anticoagulant therapy? And this is something that we always want to revisit, as opposed to, you're a male with unprovoked VTE, you're on lifelong anticoagulation. In my practice, at least, this is not what I do. I try to be a bit more selective. Yes, I know about the HER2 rule that says, all men continue and women may stop. I think that's a useful guide, but I only use it as a guide as opposed to a kind of cookbook approach. And I do D-dimer testing post-anticoagulation in males, and I don't routinely keep them on long-term anticoagulation. So these three scenarios are actually quite common, but we have to recognize that the evidence that we have to inform best practices are limited. So there's always warfarin as a default. If we're going to use an anticoagulant like a DOAC, try to consider it carefully, especially in the acute management phase of venous thromboembolism. And in general, not rely on DOAC levels to guide our management. If you're going to do that, I would only urge you to do it in consultation with a specialist. And even so-called specialists like myself don't have a heck of a lot of experience in dealing with DOAC levels and their implications for monitoring. Of course, DOAC levels, as was alluded to by one of the other audience members, in different clinical situations, like somebody having an acute bleed or needing an emergency operation or procedure, that's a very different clinical scenario. But for the purposes of this session, it's not something that we would routinely go to. All right, we're almost at the end of the 45 minutes, and I just want to make sure that we have time for our audience to bring forth any questions, excuse me, that they may have. I think there was one other comment that I may not have disseminated from Dr. Nguyen. Do you know if in studies obese patients have more bleeding? The short answer to that is no. That has not been demonstrated, although these studies are, I can assure you, not powered or adequately designed to look at whether there's a bleeding signal with DOAC use. And I guess theoretically, as I alluded to earlier, my concern would be more on the side that if they're at increased risk for recurrent disease. And okay, we're transitioning to a little bit of a different topic, and Dr. Nguyen asks about stopping DOACs pre-op. Well, in chronic renal insufficiency, yes, there is some guidance regarding that in Thrombosis Canada, and in general, if a patient has got severe renal insufficiency and they're on a DOAC, which technically is a relative contraindication, you probably want to add a day or two to the interruption interval for that DOAC, especially if it's something like a Doxaban, where 45 to 50% of it is cleared by the kidney. Perhaps less of an issue if they are receiving low dose of Pixaband. And Dr. Lai asks if there are any guidelines for DOAC use for underweight patients. So, a patient with a DVT who weighs 35 kilograms who does not want to get low molecular heparin injections. So I can tell you that I'm not aware of any good data in very small individuals like this, particularly less than 50, let alone less than 40 kilos with a DOAC. It would be completely empiric. I can tell you that there are some data in Asian populations, specifically in Japan, where people are generally of smaller body weight, and in general, the anticoagulant dosing and the anticoagulant intensity is less than in North American or European-based studies. But I even there, I don't know of good data for patients that are 35 kilos, which would be around 75 pounds or so, 75, 80 pounds. So if they're refusing an injection, you don't have a lot of choices. You can go to warfarin alone, but we know that doesn't work as well when it's not bridged with a short-acting anticoagulant. So this would be a tough one. I'd try to maybe convince the patient that there are injections that are very small caliber needles. So one of the low molecular heparins has 29 gauge needles, and this is sort of like an insulin injection. Patients hardly feel it. However, if they don't have much subcutaneous fatty tissue, I acknowledge it can be relatively painful. But this is something that I try to, I don't want to say coax, but try to reassure the patient that it will not cause substantial discomfort. And I would sort of press the need to using a short-acting heparin. Alrighty, any other questions or comments in the chat line? We're kind of going into a bit of overtime here in terms of the time, and would ask you please to take a couple of minutes to complete the survey and evaluation that Holly has kindly sent out. It is very important for us. We do look at these all very carefully and make sure that your views and your choices for topics are adhered to and acknowledged. And this is if this is where the survey is, if you can please click on that, or just copy and paste this URL into your browser. Please take a couple of minutes to do this. It is very valuable for us on Thrombosis Canada. And with that, I will bid everybody farewell and hope you have a pleasant morning, afternoon, wherever you are in Canada. And thank you again very much for your support of Thrombosis Canada. Please make sure to check the website. We've always got new stuff there, and look forward to seeing you or meeting you again in the future.
Thank you very much, Jim.
Bye-bye now.